I'm Dr. Snigdha Pusalavidyasagar. I am a sleep medicine physician at the University of Minnesota, Associate Professor of Medicine, and I practice sleep medicine, and I am also the site director for the fellowship program for sleep at our center as well. And it is a pleasure being with you today and talking to you all today about my favorite topic of research interest, which is sleep in women's health. The title of the talk is Sleep in Women Across the Stages of Life. It is a very broad topic, so I am trying to make sure I can make it as consolidated as I can, talking to you all for about half hour to 35 minutes and opening up the rest of the time for any Q&As, and we'll go from there. I do not have any conflict of interest. The learning objectives of my talk today are to promote an understanding of the changes in sleep across the stages of a woman's life, to review the common sleep disorders that happen in women across these different stages. By that, what I mean is menarche, menstrual cycle, reproductive age group women, perimenopausal transition to menopause and postmenopausal stages of life. And upon the conclusion of the program, the participants would be able to identify common sleep changes in women as they age. This is a slide I had taken from the Sleep in America poll 2018 that was conducted by the National Sleep Foundation. They tried to give some questionnaire to the participants, and 65% of the people did acknowledge that having a good night's sleep is important for being effective the next day. But in spite of 65% acknowledging that, only 10% of the people prioritize sleep compared to any other activities such as fitness and nutrition or hobbies or interests. So that is pretty low, isn't it? And when they considered comparing men versus women, 13% of women in that poll considered that sleep is really important for them to function well the following day, compared to only 7% of men who had the same response. And when they compared in the same 13% of women who considered sleep as important, the response was only good in 6% of those women who were less than 40 years old, and 12% was the response that sleep is important among the women who are older than 40 years. So what does that tell us? So even though we know it is important, we are not really prioritizing much. And we need to focus on the importance of sleep and addressing the sleep problems and prioritizing the sleep for a better health. So this is a Sleep in America poll that was conducted by the National Sleep Foundation in 2007, where they conducted a survey. They had about 1,000 participants, and they had provided them with questionnaire. And one of the aspects of the questionnaire was how often are you experiencing sleep problems within the past month? And under that, was it every night or almost every night, a few nights a week, rarely? And out of those 1,000 participants, the results showed that 67% of the women reported experiencing sleep problems within that past month. And out of those 67%, majority, which was 46%, had reported sleep problems occurring almost every night or every night, which is pretty big, and 21% at least few nights a week. So this was one of the major studies taking into consideration specifically sleep in women, and hopefully they'll be able to come up with some newer studies, because we are now in 2021. So hopefully there'll be more data in the future. So at any given point in time, women have more sleep complaints and the need for sleep compared to men. And sleep problems, particularly insomnia, hypersomnia, are more commonly seen in women compared to men. So this is a slide that I'm showing you how, as women get older, there is an increase in the prevalence of their sleep problems. If you take into consideration the age group 18 to 24 years, 33% of the women report sleep problems, whereas the decade after, it becomes 36%. It goes up to 44% in age group 35 to 44, and 46% of prevalence of sleep problems as women get a little more older, between 45 to 54. And the maximum prevalence is in the age group, which is postmenopausal after the 55, reaching up to 48%. So why does this happen? Why is it that these sleep problems get in women increased prevalence as they get older? A lot of factors that affect the women's sleep. It is the age, the different types of the hormonal phases they are in, menarche, during the menstrual cycle, during the reproductive cycle, when they are pregnant, and after the pregnancy, the postpartum period, then the perimenopausal change, the transition to menopause and after menopause. Lots of changes are happening physiologically and hormonally. And there is also a lot of activity, lifestyle changes also that happen that do contribute to this increasing prevalence of sleep disorders in women as they get older. This is again another study that was conducted by Jehan and her colleagues that was published in 2015. This is actually comparing the sleep prevalence disorders of prevalence of sleep disorders in women compared to men. The red is the women and the blue color is the men here. So if you see for both the genders, there are not much problems at all until the menarche time, and after that there's a steep increase and a continuous increase in the sleep problems in women compared to men at any given point in time. There are a lot of gender differences in sleep disorders. If you were to take into consideration some special disorders, some sleep disorders like insomnia or hypersomnia or restless leg syndrome, these sleep disorders tend to be more prevalent in women compared to men. Whereas there are some other sleep disorders that are less prevalent in women compared to men, such as parasomnia, particularly REM sleep behavior disorder, or obstructive sleep apnea. Though there are some age groups and some life milestones in women where those respiratory sleep disorders tend to be prevalent. Like, for example, obstructive sleep apnea is more common in women who are pregnant. So that particular age group, the pregnancy, that particular milestone of life, the hormonal changes, women do have a higher tendency for obstructive sleep apnea compared to other women who are not pregnant. Same way, REM sleep behavior disorder happens to be more common in men compared to women, whereas there are some parasomnias like sleep-related eating disorder that is more prevalent in women, 2 to 4 times more prevalent in women compared to men. So there's lots of gender differences that happen in the sleep disorders in women across their lifespan. So the physiological changes happening during the time of puberty, during the menstrual cycle, during pregnancy, the postpartum period with major hormonal changes and physiological changes, and the transition occurring into menopause, coupled with other issues with lifestyle changes, including childcare, work-life balance, caregiver role for women in the society, and stress. All these factors can definitely affect the sleep in the women, affecting their sleep quality, their sleep disorders, and also interfering with the daytime functioning and quality of life in some women. With regards to the restless leg syndrome, for example, I'm talking here about the gender differences because we just discussed about what are some of the sleep disorders that are commonly prevalent in women compared to men. If you take into consideration the restless leg symptoms, the blank circle here is the RLS prevalence as the age advances in men. That is almost comparable to nulliparous women with regards to the RLS prevalence, though in the nulliparous women, up until 50 to 64 years of age, it is almost similar to what is noted in men, whereas there is a sudden surge as the menopause hits, becoming even significantly more severe than RLS during pregnancy or other phases of life. And that is very much specific to nulliparous women. And these other few pictures here, the line diagrams here, you have women with one child, two children, three and more children. So with increasing parity, there is increase in prevalence of the restless leg symptoms in the women. Though when women are pregnant and have the RLS, which is gestational RLS, they do tend to decrease as they get older, unlike this special category of nulliparous women who have prevalence later in their life or on the menopause, which can be even sometimes refractory to treatment. We'll talk about that in the next upcoming slides. I want to talk to you briefly about the menstrual cycle because there's a lot of hormonal changes that are happening in the menstrual cycle, and each of those hormonal changes does have effect on sleep architecture and the overall sleep in the women. This first 14 days is the pre-ovulatory phase, also called as the follicular phase. And the day 15 to 28 is the luteal phase or the post-ovulatory phase. The hormone that is predominant during the follicular phase is estrogen, whereas the hormone that is more pronounced during the luteal phase is the progesterone, even though there will be a slight increase in the progesterone starting in the follicular phase itself, but it is maximum peak is in the luteal phase and it decreases as the menstrual cycle starts. Estrogen can suppress REM sleep. Progesterone can have more sleep promoting effects because it happens to stimulate the GABA receptors, promoting sleep. And under the influence of progesterone, people can be sometimes more sleepy. And there is sleep disruptions more in spite of the rising progesterone levels in the luteal phase compared to the follicular phase, where some women report more wake after sleep onset or frequent nocturnal awakenings. But there has been so much of controversy with that. While some studies report that, there are some studies that show that they have increased amount of stage N2, decreased REM sleep, and there were some studies where they did not really find any significant changes in the sleep architecture in women during their follicular phase of cycle compared to the luteal phase. So there's so much of controversy in that area still. But for our understanding, knowing that the estrogen is the dominant hormone in the follicular phase and the progesterone is in the luteal phase, at least we can recognize that progesterone has some sleep promoting effect. So that definitely would affect the sleep architecture in these women. So looking at the core body temperature under the influence of the estrogen in the follicular phase, the core body temperature is low, but as the progesterone increases in the luteal phase, you see there is an increase in the core body temperature in women. I'm talking now about this premenstrual syndrome and premenstrual dysphoric disorder. Premenstrual syndrome is commonly noted after the menarche in the reproductive age women. It usually involves abdominal discomfort, abdominal pain, bloating, and headache. When these patients have additional mood disorders, particularly anxiety, then it is called as premenstrual dysphoric disorder. And premenstrual dysphoric disorder, or PMDD, the prevalence is about 3 to 8% in women. And what are all the main causes for this? Again, the main reason for the PMDD is the hormonal changes. The one that is highlighted here in the red, when there is changes happening in the progesterone, which had peaked in the middle of the luteal phase and dropping off at the onset of the menstrual cycle, has significant impact on the PMDD. There is also implications that maybe there is some circadian rhythm abnormalities here, maybe some changes in the melatonin that make women more prone for PMDD. Women with PMDD often report insomnia, which can be difficulty initiating sleep or maintaining sleep or frequent nighttime awakenings. And there is also some reports that these women tend to also report some parasomnias like nightmares and night terrors, sleep terrors, also commonly during their PMDD periods. So commonly hormonal treatment has been shown to be effective in some women. And there are also some women who do benefit by circadian timing of light with exposure to bright light in the morning when they wake up and administration of melatonin in the night. So that is also a possibility. And there also has been some role for cognitive behavioral therapy in select patients, particularly who have the insomnia with the PMDD. Polycystic ovarian syndrome is an endocrinological disorder that is more common, very common in the reproductive age group women. Sometimes it can be diagnosed in the early 20s, and sometimes it could be as late as their 30s. And women with polycystic ovarian syndrome have higher prevalence of obstructive sleep apnea as well as sleep disturbances. They tend to be more obese. They also have the metabolic syndrome manifestations, which is hyperlipidemia, type 2 diabetes mellitus, hypertension, and they also are at more risk for cardiometabolic disorders as well. And women have menstrual cycle irregularities. And there is also not only changes in the estrogen levels, but also changes in other hormones like testosterone levels as well in these women. And women with polycystic ovarian syndrome have very high prevalence of obstructive sleep apnea. There is a lot of research that has been done in this particular condition with the sleep in women and pregnancy and other sleep disorders with the polycystic ovarian syndrome. So knowing that it is more commonly prevalent, it is important to identify the sleep disorders among these women, which can have effect on their pregnancies and the other cardiometabolic factors with the hormonal changes. Treating, for example, a woman who is got the PCOS is similar to how you would treat a normal person with obstructive sleep apnea, which could be a CPAP or a dental appliance more commonly. And there is also one school of thought that because it is primarily something that occurs in response to the changes in the hormonal levels, that maybe there is decrease in the prevalence of the symptoms and their cardiometabolic side effects as the women transition into menopausal age group. I have highlighted here a couple of studies that have been published, but there are more of them now. So the sleep disturbances and sleep disorders, these women can have not only have obstructive sleep apnea, they can have insomnia, or they can have mood disorders like depression and anxiety that can contribute to insomnia. They can have a poor lifestyle, and they can have other conditions as we talked about, like metabolic disease, type 2 diabetes, and cardiovascular disease. So it is important to recognize this particular condition and identify the sleep disorders. And this has become almost like a multidisciplinary approach that is needed in these patients, not only seeing them in the women's health clinic by their primary care doctors, but also having the endocrinology doctors involved, and perhaps even the sleep doctors involved, particularly in women who have more sleep issues. Sleep-related eating disorder is a very common non-REM parasomnia that is prevalent among women. And it is 2 to 4 times more frequent in women compared to men. Onset is usually in the late teens or in their early 20s. Treatment options, depending upon the underlying cause. If it is an underlying sleep apnea that is contributing or triggering this parasomnia, you would treat the obstructive sleep apnea. If there is underlying restless leg syndrome that has also been shown to have association with night eating, treating the restless legs would be the way to control this parasomnia. However, there are some medications that are also used to treat this parasomnia, such as topiramate, Topamax. So with that, I will move to the next section of the different age group of women, particularly addressing about the sleep problems in women during their pregnancy. So the sleep during pregnancy changes right from the first trimester all the way through the third trimester and continues even after the delivery of the baby during the postpartum with continual hormonal changes. The hormonal changes are very well shown in this slide to see how in the first period of the gestation compared to the last trimester, how all the hormones, the estrogens, this is the progesterone that continues to increase throughout the pregnancy, peaking towards the last trimester at the maximum levels, and the estrogen levels as well. And these hormonal levels definitely affect the sleep in women in different ways. But if you look in this middle, the second trimester, that is often where most of the levels, even though they're still increasing, they're almost stable. They are not as dramatic as they were in the initial part or in the final trimester. And most of the sleep disruptions are again in women who are pregnant, owing to the hormonal changes and other causes we're going to discuss soon, are mainly happening in the first and the last trimesters of pregnancy. Reasons for nighttime awakenings during pregnancy, they are sometimes common in first and the third trimester. And again, because the second trimester is stable, sleep problems are less likely in majority of the pregnant women compared to the first and the third. Frequency of urination happens to be the most common cause of nocturnal sleep disruption at either the first or the last trimester of pregnancy, whereas leg cramps, joint pains could happen in the first or the last trimester, but definitely cramping in the legs and joint pains, those sort of discomforts are more commonly reported as causes for sleep disruption during the third trimester of the pregnancy. Insomnia is pretty common during pregnancy, though the first trimester, the presentation in majority of the women is that they are more sleepy. And why is that? Because of the sleep promoting effect from the progesterone. And as the pregnancy advances with other hormonal changes and other sleep problems, it could be obstructive sleep apnea, or it could be restless leg syndrome, or it could be some other medical issues like hypertension or other medical comorbidities with the pregnancy or other stressors, including anxiety or mood issues like depression, can all cause effects on sleep, causing insomnia, which could be either initiation problem or maintenance problem or early awakenings or non-restorative sleep. So it is very important to identify insomnia in women when they are pregnant, and also to address and treat it because it is important for the quality of life and the overall maternal health as well as the fetal health as well. Unfortunately, pregnancy is almost like so many contraindications to treat the insomnia, or for that matter, several other conditions in the sleep aspect itself, because you definitely do not want to give any medications to the pregnant women, particularly in the first trimester, which is the main period for embryo, the organogenesis. So you do not want to really have them have any medications, but try mostly the non-pharmacological measures non-pharmacological measures including yoga, moderate intensity exercises, not too much of contact sports, but yoga and cognitive behavioral therapy and good circadian timing of light, those sort of things, and healthy living lifestyle with good dietary changes and healthy diet and those sort of things can all help. Whereas there are some women who may have severe insomnia and you have to help them and you have to consider medication. And there have been some studies where they have tried medications like trazodone, particularly in the last trimester, that has been found to be effective. Even though the antihistamines are not FDA approved and recommended for insomnia, they have also been used successfully in treating the insomnia during pregnancy. The one problem that comes with the antihistamines is worsening of the restless leg symptoms because of the antihistamines. So we have to be always careful when women who are pregnant with restless legs take antihistamines, because we should have to notify them about the potential worsening of their symptoms. And trazodone in low doses, like 25 to 50 milligrams up to 100 milligrams, has been tried in some studies to help with insomnia. And they looked at the risk of restless leg symptoms that can happen with medication like trazodone, and it was not that high. Coming to obstructive sleep apnea during pregnancy. The women tend to gain weight during their pregnancy, and their major weight gain particularly happens from the second trimester on up till their last trimester. And there are some women who may be obese pre-pregnant who are more at risk of worsening of sleep apnea during their pregnancy, whereas there are some women who do not have any existent obstructive sleep apnea who may just develop the obstructive sleep apnea, which is a transient phenomenon just during the pregnancy with the weight gain. There are some factors that protect the woman from risks of sleep apnea, and that there are some that increase the risk. So what are some of the changes that increase the risk of sleep apnea during pregnancy in women? Gestational weight gain, nasopharyngeal edema under the influence of progesterone that can cause some resistance to the upper airway, and decreased functional reserve capacity. Whereas what are the factors that offer some protection? Increase in minute ventilation because of the progesterone effect, it being a respiratory stimulant, and preference for a lateral sleep positioning as opposed to supine positioning, particularly during the final trimester, also decreases the risk of position-dependent obstructive sleep apnea. And there is also supposed to be a school of thought that these women tend to have decreased REM sleep time under the influence of estrogen. And we all know that REM sleep happens to be the particular sleep stage where sleep apnea can be more severe. So maybe by having less amount of REM, there is not much of a REM predominant sleep apnea events among these women, but it is very controversial. And how would you treat the women who are pregnant with sleep apnea? Options like dental appliance and upper airway surgery are not at all practical in them. The best treatment would be, of course, healthy diet and regular exercise, moderate intensity, and auto-titrating CPAP, which can auto-adjust the pressure settings depending upon how the severity increases as the pregnancy advances, and will help protect against maternal adverse effects and fetal side effects too. Because the maternal side effects that can happen from not treating the sleep apnea in women can be preeclampsia, chronic hypertension, gestational diabetes, and they also have been shown to have a higher risk of cesarean section for delivery methods. And fetal effects wise, they can have problems with low birth weight or intrauterine growth retardation and decreased oxygen supply to the infant, affecting the growth and everything. So both for maternal and fetal health aspects, treating sleep apnea, first of all, recognizing them and identifying and treating them is very important. In some women who are not obese to begin with and who do not have severe sleep apnea, once they lose their weight and come back to their pre-pregnant weight, the sleep apnea would resolve. Whereas some women who are obese to begin with and who have hard time losing their weight, reaching their pre-pregnant weight, may tend to have persistent sleep apnea, which would still need continuous treatment, but we need to use our clinical judgment whom to reevaluate after they lose the weight and whom to consider treatment on a continuous basis, or whom to consider treatment only as a temporary solution until things get better or the sleep apnea resolves. So restless legs and pregnancy. Pregnancy has been associated with iron deficiency to the point that ferritin levels tend to drop by almost 50% by the time the woman is in the middle of the pregnancy or middle of the second trimester compared to their pre-pregnant level. Iron deficiency is one of the main mechanisms that has been attributed to the restless leg symptoms in men and women, but more so in pregnant women. And the prevalence of the RLS increases during the course of pregnancy up to 27% by the time the woman approaches their third trimester. Predictor factors for the restless leg symptoms in pregnancy. If there is a past history of RLS, the odds ratio is high. Previous history of restless leg syndrome with the prior pregnancy is a significant risk factor. We already discussed in one of our earlier slides, like how if a woman with one child has RLS, how the prevalence increases when they have two children and how it increases even more with 3 or more children. So with increasing parity, there is increased prevalence of restless leg symptoms. Hemoglobin levels of less than 11 gram per deciliter also is one of the risk factors. And of course, positive family history for RLS also is another risk factor in these women. How do we treat this gestational RLS? The workup and everything is going to be just like how you would consider in evaluating a non-pregnant woman. But again, the same restrictions apply. You do not want to really rely on pharmacological intervention, particularly during the first trimester, and lean more towards non-pharmacological interventions like cognitive behavioral therapy, exercise, massage, yoga, iron supplements, and folate supplementation, and things like that. Whereas in some women, the symptoms of restless legs can be very bad and can be very disruptive to their sleep. And in those, definitely, you will have to consider treatment and what treatment you use depending upon how severe they are and in what trimester of pregnancy they are. Medications like carbidopa and levodopa in combinations of 25-100 or up to 50-200 has been shown to be tried in patients during their second trimester of pregnancy and the third trimester too. But again, we know the risks in the long term. Tolerance, augmentation are all commonly seen. There is not much studies, there are not many studies available on how treating these patients with other dopaminergics like ropinirole or pramipexole or rotigotine patches impact the restless leg symptoms. But of all those dopaminergics, the extensively studied one is the carbidopa, levodopa, which honestly, even in my practice, I haven't prescribed so far. Low dose clonazepam is what we have tried in select patients. By low dose, what I mean is a 0.25 milligram up to no more than 1 milligram, just before about 2 hours or so before the symptom onset, and considering when the symptom peak onset starts. And usually we know it is before, after they go to bed, usually in the evening and nighttime when the symptoms are more pronounced with restless leg symptoms. Low dose oxycodone in the range of 5 to 20 milligram is used very, very sparingly for very severe restless leg symptoms in pregnancy, particularly the refractory courses, who are not treatable by conservative measures, non-pharmacological, who did not even respond to IV iron infusions or other medications like the dopaminergics or medications like gabapentin or clonazepam. So for them, sparingly, you must use this narcotics, opioids, particularly oxycodone is the only one that is much safer compared to the other opioids that are available. Of course, you have the side effects. There's going to be respiratory suppression. There can be a neonatal abstinence. So those sort of complications also we have to be very well aware of, that there is a risk. But again, we have to consider the risk versus benefiting in managing these patients with iron deficiency and restless leg symptoms. Some women have a hard time tolerating oral iron supplements. And while we treat women with iron supplements who do not have restless legs during their pregnancy, if their ferritin is less than 30%, 30 nanogram per milliliter, and transferrin saturation less than 20%, we have to consider oral iron supplementation in pregnant women with restless legs if their ferritin levels are below 75 nanogram per milliliter. So it's not as low as what it is in non-RLS patients. And for those women who do not respond to oral iron supplementation, or they are intolerant to the oral iron supplementation, we can use IV iron infusions. The common preparations that are used are the iron sucrose, low molecular weight iron dextran, and ferric carboxymaltose. Of all those three, ferric carboxymaltose is very efficacious because it can cross the blood-brain barrier, but it is also super expensive. So the recommendation is to use the low molecular weight iron dextran as the IV iron infusion agent of choice in these women. And after the delivery, with the hormonal changes, majority of the patients' RLS symptoms usually resolve after the delivery. Postpartum sleep, postpartum period, there is high incidence of sleep disruptions. And in the National Sleep Foundation, when they did the survey, they found that 84% of women report sleep problems. 72% of women report waking up feeling unrested. 68% of women report waking up a lot. That is rapid hormone decline. The estrogen and progesterone levels that are peaking during the pregnancy rapidly decline. That can affect the mood of the individual, and also the circadian timing of the baby's sleep and the maternal demands, whether it is breastfeeding or bottle feeding, and all those responsibilities and stress and anxiety, all of those factors can affect the postpartum sleep. And it is very important to identify particularly postpartum insomnia, because in some women, managing the postpartum insomnia in a timely fashion can decrease their risk of postpartum depression, which can be seen in some women, which can be challenging to treat. And they would definitely require some antidepressant medications. And majority of the antidepressant medications, including sertraline, fluoxetine, can be used. But again, depending upon what other conditions they are having, supposing you're having a woman with restless leg symptoms, you want to be careful about giving SSRIs or SNRIs other than bupropion, because it does not have much impact on restless leg symptoms, and it also can be used for managing the anxiety and depression as well in these women. Cognitive behavioral therapy, light therapy, appropriate circadian timing, physical activity, engage in exercise, and healthy lifestyle, cognitive behavioral therapy, all these things have been really very effective in these women in the postpartum age group. There is a lot of research done also now in the area of sleep in perimenopausal and postmenopausal women, particularly what we call as a menopausal transition. In fact, I should have probably used this, told you this sentence way back in my earlier part of the presentation. Majority of the sleep studies that were conducted early on were all on men. It was only in the 1990s when they started doing studies that involved women. And one of the most important studies was a study of women's health across the nation. SWAN is the acronym SWAN study, where there was a big presentation and acknowledgement about how the vasomotor symptoms affect the woman's sleep, causing insomnia during menopause. That brought it out and got more importance. And ever since then, there has been many studies now involving women and women's health. Hormonal changes in women happen 7 to 8 years, sometimes even earlier than that in some women, and they don't just dramatically happen right at the time of the menopause. So some women experience symptoms years before they have the final menopause, and some people may just go through the menopause with bare minimum symptoms. So presentations are very different in women in the different age group. This is also a very interesting study I quoted here, sleep disturbance during menopausal transition in multi-ethnic community sample of women. And I'm sure there are more studies now too. So Jehan and her colleagues have researched on what is the prevalence of the sleep disorders during the transition compared to premenopausal, perimenopausal, and postmenopausal. The one highlighted in green is the postmenopausal group. And you see at any given point in time, sleep disorders are more prevalent in the postmenopausal age group compared to the pre or the perimenopausal women. What are the factors that cause the sleep disorders in peri and postmenopausal women? Vasomotor symptoms, hot flushes, vaginal dryness, changes in the reproductive hormone levels, declining levels of estrogen and progesterone, circadian rhythm abnormalities, and there has been some research studies that show decreasing in production of the melatonin as the women's age advances. Though there is also a controversy saying that after the menopause, surprisingly, the melatonin levels may improve. And again, the theory behind that is maybe it is the effect of estrogen on the melatonin that is causing that. It is still unclear. Still more research needs to be done in that area. They can have anxiety and depression. So mood disorders can also be seen among these women and cause sleep disruptions, insomnia, and fatigue. And they may also have other coexisting medical conditions. It could be arthritis or underlying heart conditions or diabetes or other medical illnesses that can affect the sleep. And lifestyle changes as well. So the sleep problems commonly encountered in women who are in the menopausal transition and postmenopausal group include insomnia. Obstructive sleep apnea is another sleep disorder, and the reasons or the contributing factors for obstructive sleep apnea in the menopausal women is most likely the decrease in the hormonal protection that allows more collapsibility of the upper airway, and also weight gain with lifestyle changes and sedentary lifestyle in some women, and subcutaneous fat deposition in the pharyngeal area, further narrowing the airway, has been shown to be some of the factors that can promote sleep apnea in the menopausal women. Even though the prevalence of obstructive sleep apnea in women is lesser compared to men, once the women reaches the menopausal age group, their prevalence is almost similar in ratio, men versus women. And we treat the obstructive sleep apnea same way as we treat any other woman. It could be dental or positional appliance, a device to maintain lateral position if they have a supine dependent sleep apnea, or auto CPAP, depending upon how severe the sleep apnea is and their candidacy for the treatment option. Restless leg syndrome can also be seen invariably only happening at the menopause when the woman has not had any of those symptoms at any given time of their life before. Those can be very challenging to treat. Fibromyalgia also has been shown to be a condition with musculoskeletal discomfort that can sometimes be seen exclusively in women during their postmenopausal or menopausal transitioning period, which can also negatively impact their sleep. So Baker and his colleagues did a study where they tried to evaluate sleep difficulties across the menopausal transition. The green is difficulty falling asleep. Those lines, almost like zebra lines, are like waking up several times, and the navy blue is the waking up early. What it basically says is, at any given point in time, the sleep disruptions are more during the menopausal transition, late period, and the postmenopausal. But women who undergo surgical menopause tend to have more disruptions and difficulties with sleep compared to women who undergo natural menopause. The reasons for that is perhaps the rapidity with which the hormonal changes happen. And they also found that in women who attain menopause earlier than the normal age group, like in their mid-30s or very early 40s, as opposed to the late 40s to early 50s, they also tend to have more sleep difficulties. And women who have higher body mass index to begin with can also have more sleep difficulties during their menopause transition, particularly more presentation with regards to hot flushes and things like that. Hormone supplementation has been helpful in some patients with hot flushes, but it is not recommended for everyone. Very selectively indicated, particularly with the controversy that has been happening in the research field with the hormones and heart disease and other cancers. Sometimes we have used treatment using medications like clonidine, gabapentin, and venlafaxine like medications for hot flushes, even though non-pharmacological measures like cognitive behavioral therapy and physical exercise, lifestyle changes also have been shown to be helpful with the hot flushes and night sweats in these women. Obstructive sleep apnea, we talked about a little while ago. If you look at the black highlighted bars, which is the postmenopausal, whereas the clear one is a premenopausal, at any given point in time, whatever be the range of severity of sleep apnea, mild or moderate or severe, it is the women who are postmenopausal who have a higher prevalence of obstructive sleep apnea compared to women who are premenopausal. Restless legs during during menopause is little different than pregnancy because this is not something that will resolve after the delivery of the baby, but it can tend to continue to progress and be refractory to treatment. Late onset restless legs appears to be non-hereditary, rapidly progresses with age, starting around age 50 usually, and it has been shown to have strong relationship to serum iron status. Fibromyalgia, as we said, in some women exclusively happens around the menopausal age group. The slide here shows the hypnogram where the deep sleep, by that they mean the N3 sleep, which is seen in a normal non-fibromyalgia patient. You don't really see that deep sleep in fibromyalgia patients. And that has been, old research studies have shown that too, that women who are in chronic pain and fibromyalgia may not have adequate amount of N3 sleep, and it is important to have certain amount of N3 sleep for pain management as well as for restorative feeling when you wake up in the morning. So fibromyalgia women usually often report less amount of N3 sleep. Fibromyalgia begins after menopause in some patients, though we see fibromyalgia in women even around like ages 30 or even younger. 1/3 of the women with fibromyalgia report early menopause. Menopausal women with fibromyalgia experience symptoms with greater intensity than women who are non-menopausal. Abrupt decline in hormones with surgical menopause or shorter exposure time to ovarian hormones like in early menopause can be having more manifestation with worsening of pain when they have this fibromyalgia. And hysterectomy, whether it is total or partial, with or without oophorectomy, can also be highly related to pain and worsening of the physical functions. So we have to recognize this entity of fibromyalgia affecting sleep in women and treat them appropriately. The commonest medications that are used to treat are pregabalin, gabapentin, and amitriptyline, but there is more research that is done with amitriptyline particularly. And of course, aerobic exercises and lifestyle changes and CBT also have been shown to be helpful in these patients. My last couple of slides are going to be like the miscellaneous things that can be seen in women that we can't ignore. Shift work is becoming more and more prevalent with our 24-hour society we are in. 12 to 28% of working women are working on different shift work schedules. 12% women work more than 48 hours per week. There are implications with the women's reproductive health and physical health and cardiovascular risk with the shift work association. There has been a lot of research that has been done, particularly among women nurses and shift work association. There could be menstrual irregularities, there could be preterm labor, increases for C-section. They also can be at higher risk for some estrogen-dependent cancers like endometrial cancers. There also has been research that sometimes some of these women who do shift work, particularly rapidly changing work, shift work, that they can be more sleep deficient and have a higher tendency for weight gain and cardiometabolic adverse events. And as women get older, they have their own health problems and also can be caregivers to their other family members. And in a study with the Women's and Alzheimer's poll in 2014, they found that at any given point in time, whether it is for less than 1 year or for more than 5 years, it is always the women caregivers who are more common than males as caregivers. So that is another entity by itself that can impact the women's sleep and affecting their sleep in general and sleep health. So we have to be aware of that also. So work-life balance, lifestyle changes are very important while we are considering treating the sleep disorders in women. My conclusions from this talk: sleep problems are common in women of all ages. Physiological, hormonal, and lifestyle changes all impact sleep. Regular screening for sleep disorders is important at every single lifestone we come across. Effective treatment will result in improved health and enhanced quality of life in these women. Thank you all. And I'm open for any questions if anybody has. And this is a very vast topic. I probably should have like one way to think about it is like dividing into different age groups, but the compact one that just gives a gist of the whole thing in 45 minutes. Maybe I took longer than that.
Thank you for answering the questions. We do have time for questions. It's 10:54, so if you've got questions, again, feel free to put them in the chat or just unmute yourself and you can ask it directly. Yes, the presentation will be shared. The video will be edited and posted on the website, on the AASM website in a couple of weeks.
And you also can feel free to ask me questions via email. Also, at any point in time, I'm happy to help answer your questions. My email address is pusal001@umn.edu.
What is the oral iron preparation you prefer to use for RLS?
Ferrous sulfate is the most commonly used one, or ferrous gluconate. And slow iron tablet is another one that we recommend for people who have issues with intolerance, particularly with the GI side effects with the medication. Vitron C, which is the vitamin C in combination with the iron preparation, which is primarily intended with the vitamin C enhancing the absorption of iron, is not that commonly recommended during pregnancy. The rationale is unclear, but usually the preparations that are given are without the vitamin C, which is iron sulfate, iron ferrous gluconate, things like that. That is for oral. And again, the prenatal vitamin supplementation has an iron component in that, but when people have restless leg symptoms and ferritin levels are less than 75, you do consider extra iron in addition to whatever iron is in the prenatal vitamin tablet. Any other questions?
Often postmenopausal women are complaining of waking up like clockwork around the same time every night. Any thoughts as to why?
That could be depending upon the underlying sleep condition. As I said, the menopausal women can have problems with obstructive sleep apnea. And if it is a REM-related sleep apnea, they may have this awakening around 3 o'clock or 4 o'clock. Either they wake up to use the bathroom or they have no apparent reason and they have insomnia after the awakening. So it could be obstructive sleep apnea. or they may have an underlying anxiety or depression that is affecting your sleep, or it could be a psychophysiological component. So it could be multiple ways that the patient could present. There's not like one single thing that you can pinpoint to, but with the clock work like that 3 a.m., 4:30, very much suggests most likely a REM-related event like sleep apnea.
Thank you. I am putting your email address in the chat for everyone because someone asked if I could add it to the chat. Is that okay with you?
Oh yeah, totally. I even announced it is pusal001@umn.edu.
When do you prescribe IV iron instead of oral in pregnant women?
Usually it is either during the second or the third trimester that the IV iron infusion treatment is considered. The first trimester, usually it is mostly oral iron supplementation. Whereas if the women's ferritin levels are very low and they have severe RLS, even if the ferritin level is less than 75 nanogram per milliliter, but they are having hard difficulty sleeping because of the restless leg symptoms and they are unable to tolerate the iron supplement orally, we can recommend providing them with IV iron infusions. Most commonly, second and third trimester, to answer your question specifically, and even more commonly would be the final pregnancy trimester, particularly when cases are very severe and refractory to treatment. It is safe and effective. In some, again, some people, you still, even though you have given iron infusion, you may still need to consider even stronger opioids like oxycodone though.